All right. Well, first of all, thank you so much to the organizers for inviting me. It's great to have a chance to talk about some of these issues, which I think are very important. And we're going to take a slightly different view of some of the challenges posed by COVID to us internationally and nationally. And I should say I'm a professor here in the medical school and School of Public Health, and I direct the Masters of Bioethics program here. So in terms of bioethical principles that we draw on, obviously, and many of you may know this, we look at autonomy and respect for persons as being important, beneficence, non-maleficence, or doing no harm, and justice. But of course, COVID is illustrating how these can conflict in many ways. So there are ethical concerns that arise with our responses to the COVID pandemic, both as individual providers, as researchers, as citizens, as voters, et cetera. And obviously, healthcare institutions and policymakers have a large number of ethical concerns that they're wrestling with. So there, on the one hand, are needs to prepare for future public health emergencies. And unfortunately, in the past, I would argue we did not adequately prepare for this public health emergency. And there, I think one tension is one that we will always have, which is how much do we focus on current needs and current benefits of use of resources versus how much we should invest really for possible future emergencies, and how much of our resources in healthcare, for instance, do we give to possible future emergencies such as COVID before it happened. And of course, there's evidence that there was the possibility of other COVID viruses after SARS, and not enough attention, many of us feel, was given to that possibility. So with regard to prevention currently, once the pandemic starts, of course, there are major social and public health questions of how do we enforce or encourage social distancing and lockdowns? Should we enforce it? In some countries, they have police arresting people or giving tickets out if you violate social distancing, if you are outside without a mask, for instance. In some countries, the military has been called in. And of course, these are questions that we face between balancing what we feel are our rights to autonomy, to people being able to do what they want, versus the greater public health concern, both for their individual health and for the health of other people whom they may infect if they have COVID and are not aware of it. So again, a tension between how we weigh individual rights versus need to protect oneself and others. And obviously, in clinical care of COVID patients and of other patients, there are ethical concerns, questions with research and reopening, as I'll talk about in a moment. So in clinical settings, there are obviously concerns, and these have been in the news, about triage, how we should allot the limited number of supplies or resources that we have, who should get them, and how should these decisions be made, and who should make them, how transparent they should be. They need to be transparent. People need to be informed about them. And again, there have been failures in many cases about these issues. So we have personal protective equipment. PPE obviously is crucial, but there have been limited supplies, and some hospitals in the New York area, for instance, decided they would give them to doctors but not nurses. They would say doctors had to wear them only when seeing a patient, but not in the hallway. And I should say that whereas we in the New York area have been fortunate, knock on wood, in having past this initial peak, we now see rising cases of the disease in other states, in Texas and Florida, where they are having excruciating limited supplies of essential equipment. Obviously, with allocation of resources, this too presents triage questions here in the New York area. There's been a lot of criticism, for instance, of the fact that during the height of the pandemic here a few weeks ago, there were a lot of patients being taken by ambulances to hospitals in Queens, which were completely overridden, whereas there were empty hospital beds for COVID patients in Manhattan that remained empty. And of course, how do we coordinate between hospital systems that often compete, that are not coordinated, et cetera? And I think this speaks to the need for the state to be involved in, and I'll come to some of the challenges that have come up about that. With medical staff, there are concerns about triage as well. So whereas usually we have one nurse for every one patient in an ICU, many hospitals reduce that ratio to one nurse for every 4 patients. So the question is, how low can you lower the standard? Who should make that decision? What should you do? Obviously, there were a shortage of ICU beds. This was more readily addressed by shifting beds from other uses too, becoming ICU beds, but that meant there were fewer beds for patients with other conditions. And again, I think in retrospect, I think this could have been done differently in many hospitals in New York, and this is now a major issue being faced in hospitals elsewhere in the country. With ventilators, there were guidelines in New York State, for instance, that were never approved as law, but existed on paper for making allocation decisions that were based on sequential organ failure assessment, or SOFA scores that look at degrees of dysfunction in 6 organ systems. But as you note at the bottom of the slide here, there was a lot of pushback once these were promulgated, even though they still did not have the status of law, with disability advocates, and saying this is going to disadvantage people who have disabilities, may potentially not get ventilators. And of course, a major issue that we all need to think about is the fact that certain ethnic and racial groups appear to be more likely to get COVID and to get sick from COVID, partly due to poor access to healthcare systems beforehand, partly to other factors. But again, it's possible that the ventilator guidelines that were developed pre-COVID have not generally taken these factors into consideration enough. And I think that there are things that we still need to do. Luckily, it looks like we've missed the bullet, or we bypassed the bullet here on this first wave in New York, but it is appearing elsewhere. I think there are ways of addressing this. I think, for instance, even though someone may have Down syndrome, that doesn't mean that they should not get a ventilator. It really should be based on the likelihood that they will survive to discharge. That is, if there's a limited supply of ventilators, they should go to people who are most likely to survive if they get a ventilator, and people who would be most likely to die if they did not get one. And it should be based on survival to discharge, so that even if you have Down syndrome, if your organs are functioning, that the fact that you have Down syndrome should not count against you. But again, these are areas that we've not had to really deal with as much and need to now. There's also ongoing issues, I think, with medication availability and costs as new medications are developed and found to be effective. So remdesivir, for instance, costs more than $2,000 to $3,000 per patient, depending on insurance. Many of us feel that drug costs in general in this country have been too high. And again, this is going to come to the fore again with treatments for this pandemic and vaccines as well, once we develop them. And of course, another issue is undocumented immigrants. Many of our persons of color, they may be more likely again to either get COVID. Often they don't have the luxury of having a lot of personal space at home. There may be 5 or 6 people sharing a relatively small housing situation, and so they may be more likely to get COVID if it enters into the household. And again, we lack insurance coverage for them. The government has allocated funds to help hospitals with COVID, but many economists feel these are going to be insufficient. So there are challenges with crisis standards of care. So in New York, for instance, Governor Cuomo said that doctors could not be, and hospitals cannot be sued if they're following crisis standards of care, if they're following the rules that are legally approved, but he never approved any rules. And so doctors now could be sued if, let's say, someone's in an ICU with only 1 nurse for 4 patients and a patient dies. A family could say, look, that's not the usual standard of care, and that's why my loved one died. And unfortunately, there's still no legal immunity, legal protection. Many of us have argued that there should be protection by states for doctors who are acting in good faith, not being negligent, who are following crisis standards of care. Part of the reason state governments have not wanted to do this is because to decide who should make these triage decisions, many of us have argued that there should be a committee. It should not just be a doctor deciding about his or her patient, but it should be objectively done. And there's a fear that those committees would be labeled to be death panels, which have become politically tainted due to Sarah Palin, et cetera. And so a lot of governors around the country do not want to adopt these standards because they're afraid they'll be accused of having created death panels. And so these are major problems. Questions with nursing homes, and this too has been in the press. Do we use the same immunity policies if we have them for all nursing homes, no matter what they do? How do we decide? Again, major ethical issues. And I thought I'd lay out some of these issues just to give you an idea of the breadth of what many of us in bioethics are working on and thinking about. In research settings, there's a lot of questions about informed consent, given uncertainties about the course of illness, the newness of COVID. Some of these are things we've just heard about. Questions about capacity. There are often neurocognitive deficits that are caused by the virus, as well as from patients having acute respiratory distress syndrome and just being in an ICU, sedated for a few weeks often. Difficulties faced by surrogates come up because whereas in other situations, if a patient cannot decide for him or herself about being in a study, a surrogate family member can decide, but here surrogates often are unable to visit patients in hospitals because of COVID, and they are less aware or less sensitive to the crisis the patient may be facing. Obviously, FaceTime can help, but not all the time. There are limited staff. PPE can impede communication. If both the staff member and the patient are wearing masks, it may be very hard to establish a kind of trust that's important in patients feeling comfortable being in studies, and these are issues as well. Another set of problems is that there's obviously a huge push to develop interventions, tests, effective treatments, effective vaccines, but many questions still arise, obviously about the sensitivity and specificity of tests, rates of viral mutation, lengths of patient immunity that may happen if one does get a vaccine that may be partially or fully effective, what the roles of antibodies are. Many vaccines are looking at antibody titers as the endpoint rather than actual immunity to the virus itself. And there are potential costs of rushing research in these ways. There have been a number of papers that have been retracted from major journals about COVID. Often there may be accidental errors, but of course, generally humans, if we're pushed and rushed, are more likely to make errors, not have a chance to double check our work, et cetera, and this could lead to problems. In terms of vaccine development, we obviously want rapid vaccine development, but vaccines historically take 10 to 15 years to develop. For HIV, for instance, researchers have been looking for 30 years for an effective vaccine and not yet found one. There are various shortcuts being taken by funders and others, and questions will risks ensue. At the same time, there's concern about the fact that people are desperate for a vaccine for treatment. I think vaccine particularly because there has been a thought widespread out there that as soon as we have a vaccine, we can open up the country's economy and return to normal. So there's a lot of money being put into this, but there are questions. How effective and as safe should a vaccine be for the FDA to approve it? What if a vaccine's only 50% effective? What if it's only partly safe? What if it has a 20% chance of bad side effects, perhaps 10% chance of risk? And of course, many of you may remember when swine flu vaccine was administered to around 45 million people in the late 70s, it led to increased rare but increased risk of Guillain-Barré syndrome, and that of course fueled anti-vaxxers, a lot of public concerns, fears. There's already anti-vaxxers even before we have a vaccine for this. And so we need to be very careful in what we release. And so there's a tension here between rushing and coming up with a really effective and safe vaccine.
Robert, just giving you your 2-minute mark.
Okay. There's possibilities of infecting healthy vaccine trial participants, people who are willing to have this done, questions who should get vaccines. We're interrupting studies of other conditions. We need to maintain ethics. There are concerns with recruitment into studies, given that COVID disproportionately affects certain ethnic and racial groups. Who should we give priority to in terms of being in research or getting treatment? Public health interventions, there's been suggestion of electronic surveillance using tracing apps to monitor self-quarantine or social distancing. Obviously, there are privacy concerns. This has been acceptable in some countries, less so here. Questions about reopening, I think, when and where. There's a lot of, again, ethical tensions. We need sufficient testing and contact tracing, but it's often lacking. And here again, there's often political and economic rather than ethical and public health considerations. A lot of misunderstandings. I think people think flattening the curve means we don't need to worry about it. There's fake news. I think there's a huge need for public education messaging. And in short, then COVID, I think, poses critical ethical challenges in a range of settings, clinical settings, research, public health, public policy. I think we need to maintain highest possible ethical standards, obviously, but I think there's a lot of challenges. We all feel desperate. There's a lot of pressures, political and otherwise. And I think education of providers and of patients and of the public at large is critical and something that we still need to actively do. So thank you very much, and I'd be happy to answer questions.
Thank you, Robert. Let's see. I don't see any questions right now. There's one question online by Siddhartha Dalal. For SOFA, should years of potential life left be one of the factors as many economists have advocated?
So I would say ethically, no. I think it's better as a first pass to look at simply who is most likely to survive if they get a ventilator and would be most likely to die if they don't get one. So if someone's going to die anyway, they shouldn't get one. If someone's going to survive anyway, they shouldn't get one. I think if there's a tie, if there's 10 people who have equal SOFA scores and you can only give it to 5 of them, give the machine to 5 of them, then I think you consider life left. I think you want to be wary, though, of things like quality of life. You certainly don't want it to be, you don't want to use first come, first serve. You don't want it to be a lottery. You want to have it as objective a criteria as possible. You also don't want to say, well, they're old, so we'll let them die. I think we need to be very careful about those kinds of social considerations because people will be angry about it. And also, I think, obviously, with racial and ethnic issues also considerations, we need to factor in these and think about how to include them. I think these are challenges, but I would not use age as a first pass.
So Robert, it seems to me that if you have to decide whether to give ventilator to people in identical condition, one being, I don't know, 15-year-old and one being 85, I think ethically it would make a lot more sense to give it to the 15-year-old, just so. How do you justify what you just said? It's not clear to me.
Well, so I think if there's a tie, yes, I think then the younger person. So I think, but we need, so in that case, yes, all else being equal. I think the area that we've not yet fully figured out is what to do with the fact that that may end up meaning that ventilators go more often to white people than to people of other ethnicities. So in other words, we may need to include those factors as well in some way. But we need to think about, is it equitable that in the end, let's say, people of color end up getting fewer ventilators because they have other given SOFA scores. So we may want to then address that as well as a factor.
That was a good intro to the question that you're going to get from Margaret. Margaret, you can ask yours.
Hello. Thank you for your talk. Look, I want to talk about obviously these racial and ethnic issues, because clearly, given the numbers and the way the breakdown is happening now, if the idea is, yes, we're going to give it to people who are likely to survive, there's a very real possibility, not only probable, but frankly likely, that decisions will be made not to give it to certain populations, people of color, right. Because the statistics are showing that they're more likely to die. So I get what you're saying, but nonetheless, then we wind up where I said we might wind up several weeks ago, and that is slipping into genocide, right? Where certain people are not going to get the ventilators, and this has been the fear all along. And to the degree that it is sanctioned by anybody, then, that leaves people, great masses of people, very vulnerable to being simply left to die, whether it's due to age or whether it's due to ethnic background. And that is an absolute problem.
Yeah, I completely agree with you. And I think that the ventilator guidelines that were developed, even if they're not the status of law, but sort of are being followed in many places, have not fully considered that. And I think this is a huge, huge problem. I think that to be honest, we've not yet figured out what to do. Because I think I agree completely with you. I think overall, what this highlights is our broader failures of our healthcare system, that we need to be providing better access to care earlier on. And unfortunately, what COVID has done is it's exposing a lot of the broader social, political, economic problems in our country. And I think, if anything, I hope that this will lead to calls for better healthcare access, for better health insurance. I personally think that a single payer system would be great. But already there's huge pushback to the Affordable Care Act prior to this. And I think that hopefully this will get the public to see that we need to have a much more equitable healthcare system overall. But I agree with you, these are huge, huge problems. I think that we need to really think, all of us, how to address this. How do we decide who should get resources when there's limited supplies? I think this comes up with prices of drugs as well. So who's going to be able to afford the $2,000-3,000 of remdesivir? And I think that, again, this speaks to huge needs that politically, and I think that we as physicians need to advocate for our patients about these issues.
Yeah, I mean, and I understand and I appreciate that, but you know, under the circumstances of COVID-19, I'm not sure we have the luxury of time. I mean, the time of that it will take to, yes, we need to have policy changes. In that time, literally the demographics of the country could be significantly altered. And so, you know, again, if there are these sort of quiet ethical decisions about who gets to live and who doesn't, who gets a ventilator, those are life and death decisions.
Yes.
And I'm concerned that, yes, you know, maybe it's 5 years from now, or maybe it's 2 years from now where the decision is made that we need to have alterations in the healthcare system. But the fact of the matter is you could have great swaths of the population that are simply dead. And that is a problem. And furthermore, once it gets out that people are, yes, we're making these ethical decisions about who gets a ventilator and who doesn't, I can assure you that people of color are going to start making the decision, well, maybe I ought not go to the hospital. Right. And then you're going to wind up with a situation where things are spread even further. So, and the problem is even more complicated. So I really think, I mean, I know understand that it's complicated, but those complications are serious and significant. And the idea that we don't have enough ventilators to go around. So therefore, if you're a person of color and the statistics show that you're more likely to die, we're not going to give you a ventilator. What is the point of the hospital at that point?
So
I mean, there just isn't a point.
This is why many of us have been pushing the governor to come up with a transparent system of how to approach these issues. Because unfortunately, when the governor has not come up, who knows what's going on in hospitals around the state making these decisions.
Well, I mean, yeah,
yeah. So anyway,
Margaret, we need to keep this short because unfortunately we have to move on.
And let me, if I could just say, so I think please join us in these discussions because we're pushing the governor's office to come up with ways of thinking about this so it's not just done by doctors here and there. And the problem is when the state has refused to act, as in New York and as that's now happening in Texas, it leads to these problems.